morning once again. On behalf of Diabetic Research and Welfare Association, we welcome you all. Now I would like to request Dr. Vijay Patni, Secretary of Diabetic Research and Welfare Association, for the welcome address.
Good morning, all of you. On behalf of DRWA, that is Diabetic Research and Welfare Association, I welcome you all to this scientific symposium on gestational diabetes. It's my privilege to address such a learned and esteemed audience. At the outset, I express my gratitude to the speakers and the panelists who have consented to share their knowledge and enlighten on this subject. Some of them have graced this occasion from different parts of the country as well. I also thank Eli Lilly and Boringer, who agreed to be the participant in this academic event. Now, before we really start on the panel discussion, it becomes imperative on my part to introduce our organization, Diabetes Research and Welfare Association, to this gathering, which is practically a mix of diabetologists, consultants, physicians, and gynecologists. Though our association has got registered in June 2013, we have been active for the last 4 years. As the name suggests, we are active in all the three, that's academic, social, and research. Our main activity being monthly CMEs, where we deliberate on clinical cases, genuine clinical cases in diabetes and allied topics. It is usually a roundtable meeting where we encourage young and new speakers to come forward with their presentation. Recently, we celebrated the World Diabetes Day and screened close to about 400 people for diabetes, hypertension, and ischemic heart disease. Every year we organize an annual conference over 2 days involving mainly the subject being diabetes and its comorbid conditions. Recently we have started a quarterly newsletter, probably from the first quarter starting from October, which will contain both medical as well as non-medical articles. The copy of this newsletter is probably there in your delegate kit. So with this practically we will start the event now. So we now need to proceed to our scientific agenda, and interestingly, we are starting with a panel discussion, which is usually not the norm. The panel discussion usually ends. So, which again is a deviation from the usual CMEs. This will basically kickstart the event and introduce the subject of gestational diabetes, and will act as a prelude to the main session on gestational diabetes. So I'll be moderating this particular part, and therefore I request our panelist, who happens to be the eminent diabetologist of the city, to come on stage. And today's panelists are Dr. Emil Bansali, please come on stage. Dr. Samudra Gupta, Dr. Rahul Jain, Dr. Kamanash Bhattacharya, and Dr. Kitendra Satpathy. Thank you. Come and we'll discuss that. So this panel discussion, basically what we plan to do is, we are going to touch on all aspects of GDM in a very short way, and this won't be followed by any question answer session. Once we get absolutely basically a preview of GDM, then we will go for the tea break again, and then we'll start our speaker program. Okay? You have 2 bites there actually. Now what I'm going to do is basically, I'm going to put forward few questions, almost in the line of what the speakers are going to speak. So the first question is for Dr. Satpathy. How do we define hyperglycemia in pregnancy, and what are the glycemic goal in pregnancy? This is basically our diabetologists take. Let's see what they say. Yeah, Dr. Satpathy.
Good morning. Hyperglycemia in pregnancy is increased glucose intolerance in patients, and actually it is seen in high-risk patients and can be discussed under two headings. One is diabetes with pregnancy, another is gestational diabetes mellitus. Diabetes with pregnancy means a diabetic patient going into pregnant state. And a gestational diabetes patient means a patient who was non-diabetic previously and on first instance of getting pregnancy and diagnosed as diabetes during the pregnancy. That is a state of glucose intolerance in first diagnosed in pregnant state. And both two things are quite totally different almost, because the cutoff points of a diabetic patient going pregnant is, we all know, that is HbA1c of more than 6.5, which is the normal diabetic parameters, and a fasting of more than 126. But for GDM patient or gestational diabetes mellitus patient, the parameters are quite different, because the first, according to different bodies like ADA and international groups, the fasting is about 92 or above, and a 2-hour postprandial glucose is 140 or above. And our Indian group, the DIPSI group, suggests that 2-hour 75 grams glucose tolerance test should be done, and the goal, that the target is 140 or above to diagnose as gestational diabetes mellitus. This is in a nutshell what are the things to be seen in a diabetes patient with having pregnant and a gestational diabetes mellitus patient. And the glycemic targets, that is what should be the goal of treatment of a gestational diabetes mellitus patient, is almost same for both cases. All the gestational diabetes or diabetic patient becoming pregnant are almost same, because our treatment goal is to have a baby who is less with less complications. We know many things like increase weight of the baby, and the fasting target should be around, after treatment should be around 90, and the postprandial target should be around 110 to 120, and a mean plasma glucose target should be around 105. This should we all look after treatment with anything, those who are in the guidelines. Yeah, thank you.
Oh, thank you, Dr. Satpathy. We are not taking any questions on that. The next question goes to Dr. Samudra Gupta. Why maternal hyperglycemia can affect the fetal outcome?
In pregnancy, it's a state where a fetus is actually a sort of foreign body inside the mother, and to adapt to the fetal metabolic needs, the mother has to undergo significant metabolic parameter changes in her body to give growth to a fetus and ultimately to a healthy child. And during this approximately 38 weeks of pregnancy, the mother has to undergo significant metabolic changes with the placental as an organ, also delivering some hormones which are counter-regulatory to the body. So what happens in the early phases of the pregnancy is to meet the metabolic demands of the fetus, which undergoes growth from weight 0 to say 3 kilo at childbirth. this entire journey has to be ascertained from the metabolic parameters of the mother. So there is at first significant hyperglycemia is because of the insulin. When the glucose needs of the fetus increases, the mother has to produce more metabolic substrates for the child to grow, and in that process, insulin in the body of the mother increases significantly. As a result, what happens is there is a significant demand-supply mismatch at the end of, say, approximately 16 to 18 weeks, when the placenta itself starts producing some hormones in the body, like HPL, human placental lactin, and prolactin and cortisol levels, which grows high. So in an initial phase, the insulin level rises, and there is a counter-regulatory hormonal changes from the placenta, which causes a reversal of the symptoms. So the cutoff point for screening for diabetes should be at 16 to 18 weeks, and again in 24 to 28 weeks, where you definitely have to check the blood sugar of the mother, and the oral glucose tolerance test is probably a better test. But the DIPSI guidelines also have significantly shown that one-point study of the 2 hours glycemic goal is also very important. What happens to the fetus as a result of these hyperglycemic excursions is that the baby has an inborn pancreas which starts functioning from the 9th week onwards, and approximately by 16 to 18 weeks, the pancreas can produce beta cells, and the insulin levels in the fetus also increases. As a result of the hyperglycemia, the insulin production by the fetus pancreas causes a macrosomia in the baby. But when a patient is diabetic from the beginning and not a gestational diabetes, where as Dr. Shatpathy said, that the metabolic changes are different. When a diabetic mother becomes pregnant, she is already a diabetic, and there is every chance of having an early fetal loss, some neural canal defects and endocardial cushion defects in the child. But with gestational diabetes, where the hyperglycemia starts de novo in the gestational period, you find that the problem starts from the say 24th to 28th week, where the fetus suddenly starts increasing their body weight, and fetal macrosomia, shoulder dystocia, and these problems will happen during the labor time. And immediate in the neonate, there is a chance of hypoglycemia, hypocalcemia, the child that acute respiratory distress syndrome, and these complications do arise. So these are the negative outcomes, and which has been highlighted by a study, very important study, which was conducted in 1999, called the HAPO study, which is hyperglycemia adverse outcomes in pregnancy. So that is a very important landmark study which helped us to give those values of 90 to say 153, the values which you see for gestational diabetes, as Dr. Shatpathy said, are because they said that the adverse outcomes has been documented with these sort of blood sugars where the excursions are very high. So these are in a nutshell about the complications which a fetus undergoes. And to the mother, it has been seen that the gestational diabetes mothers go on to become diabetics in future. Because it's a very stressful situation for the mother, and it's a insulin resistance syndrome as such, and which gives a precursor to the future development of diabetes to the mother as well.
Thank you, Dr. Gupta. Now, the third question goes to Dr. Tamanash Bhattacharya. What do you think about the lifestyle management in JDN?
Good morning to all. Basically, to me, gestational diabetes, I think that it is either an unidentified pre-existing disease, which is manifested due to the stress in pregnancy, or unmasking of compensated metabolism already, which is occurring inside the body, that is being unmasked by the pregnancy stress, or it is due to the direct consequence of the altered metabolism of maternal mother due to maternal hormonal milieu. Now, if we address it, then we have to think that the mother, expectant mother, she needs psychological support, physical support, social support, as well as financial support for her lifestyle management. We, in other diabetic patients, we always ask for this amount of exercise, both aerobic or resistance. But in most of the cases, in GDM, the patients or the mother or the lady who has got the history of miscarriage, history of bad obstetric history, those patients we might not be able to advocate that amount of physical exercise. So I personally prefer that patient who is advised not to go out, who is advised to stay on bed, she should use her upper arms and the upper torso exercises so that it would not hamper or it would not create any increased risk of loss. Number two, the diet. We always advise the patients to take their saturated fat intake less than 7% of the total caloric intake. Cholesterol should be less than 200 grams. And of course, we advise the patients who has got some lipid abnormalities where we cannot use the medicines like statins or fibrates. We advise them to take fish oils. We advise them to take either in formulated or the natural sources of icosapentenic acid or DHA. There are some evidences, but we should make the patient aware. And one more thing, which is the patient is very apprehensive regarding her insulin. If the always thinks that if hypo occurs, whether it will affect her baby, the patient or the mother should be advised that insulin in no way crosses placenta. So if we can communicate in that way, so patient's hypoglycemia should be kept as low as possible, and for that matter, the patient, the total intake, daily intake should be spreaded along the day, and the mother should keep always her BP checked more frequently to avoid the foods, avoid the junk foods more strictly. So medical nutritional therapy as well as aerobic exercise is one of the cornerstone of GDM therapy, because in some aspects where we cannot use medicines, where we cannot use statins or a good amount of antihypertensive drugs, stress relieving exercises, behavioral studies, and more communication with the patient is much more important, particularly in this GDM. And patient, I should mention it here, that patient should be, particularly the patient who is on insulin, the lady and her associates should become stressed upon using glucometer and the role of SMBG. This is the way we should change her lifestyle for a better outcome of pregnancy. Thank you.
Thank you, Dr. Bhattacharya. I think the speakers will give more about the lifestyle management later in the day. The next question goes to Dr. Bansali. Would you recommend oral anti-hyperglycemic agents in gestational diabetes?
We know that when lifestyle measures fail to achieve target of our glycemic control, insulin is the gold standard treatment. But insulin requires multiple injections, it requires storage in freeze, right technique, so that is not always possible in our economic situation, because so many poor people, so many places in villages, it is not always possible. So now alternative form of treatment, that is oral anti-diabetic drug, that is metformin and glibenclamide. Nice guidelines now are recommending these two drugs, metformin and glyburide, for GDM patient, as well as American College of Obstetrics and Gynecologists. They are also endorsing these two drugs for GDM patients. But US FDA has still not approved, ADA has not recommended any guidelines to use OAD in GDM patients. So metformin, as we know that diabetic pregnancy is a stage of insulin resistance due to so many contra-insulin hormone, as already discussed. And there is also some genetic secreted effect also. So these two drugs, metformin and glibenclamide, they are suitable to use in GDM patient. We know that metformin, it fully processes the placenta, but it is not teratogenic. And metformin dosage we use is 1 to 2 gram per day. It causes less maternal hypoglycemia, it causes less maternal weight gain, and in PCOD patients who are on metformin, if we continue metformin, in them incidence of GDM is reduced drastically, and there is less gestational hypertension in the patients who are using metformin. Secondly, metformin for neonates, there is no excess congenital malformation with metformin. Macrosomia incidence is reduced as compared to insulin, and then neonatal hypoglycemia, that is also less as compared to insulin. And then these children were assessed 2 years after pregnancy. Their motor and psychological development were normal. And there are few studies in mothers who received metformin. In their offspring, there was more subcutaneous fat. Overall fat was normal, but subcutaneous fat was less. So subcutaneous fat actually is beneficial, and visceral fat is more dangerous. So it is also beneficial. Only thing that in one study there was increased preterm delivery. That is in between 35 to 37 weeks, and delivery was advanced only by 1.7 days in that study. So metformin can be used in GDM patients, and PCOD patients who become pregnant, it can be used and it can be continued throughout the life. Or even if we are using insulin, then also we can add metformin, that will reduce the dose of insulin, and there will be smooth control of maternal blood sugar. Second molecule we are using is glibenclamide. Glibenclamide, in few studies there was no drug in cord blood of newborn, and in one study there was this placental transfer was there of glibenclamide. There is slight increase in incidence of macrosomia and neonatal hypoglycemia with glibenclamide, but this preeclampsia as well as preterm delivery was not there with glibenclamide. Slightly there was increased incidence of hyperglycemia in hyperbilirubinemia in newborn in glibenclamide group. So glibenclamide can also be used in GDM patients. In one study, 88% patients who were on glibenclamide, they achieved target blood glucose, and it was slightly less than insulin group. So achieving target blood glucose is more important to reduce all the side effect on newborn as well as mother of GDM. So now we are having some early at least evidence that we can use these two molecules, metformin and glibenclamide, in GDM. In South Africa, it is used for last 30 years. In Australia, it is being used. In European countries, it is already used, and there are few reports from India that we can use oral anti-diabetic, these two oral anti-diabetic drugs in GDM patients. Of course, there are no reports for first trimester use of